Hi, my name is Isa Smirstik. Support for this episode and the following message come from Audible, where you can get access to nearly 200,000 audiobooks. I recommend The Ghost in My Brain, How Concussion Stole My Life, and How the New Science of Brain Plasticity Helped Me Get It Back. This book needs no further explanation. This book or any other can be yours for free for 30 days if you sign up on audibletrial.com/brainwaves. That's audibletrial.com/brainwaves.
Hey listeners out there, Jim Siegler here for Brainwaves. In the next few weeks, you'll be hearing from two epileptologists about the non-pharmacologic management of patients with epilepsy, in particular the minimally invasive surgical options. Now, we already talked a little bit about the anterior temporal lobe resection, or ATL, in certain epileptic patients back in episode 65 with Tori Robinson. There is level 1 evidence to support this procedure in appropriately selected surgical candidates. But what I want to review today is how we go about doing this procedure, when we do it, and the risks and benefits associated with it. And after this episode in the Quanta series, you'll learn more about how surgery is not the only option for patients who failed 2 or more anticonvulsants.
So after a patient has tried at least 2 anti-epileptic drugs at optimal doses,
this is Dr. Danielle Becker, an epileptologist at the University of Pennsylvania.
And they are continuing to have seizures, that is the recommended time that we would refer them, or at least start the investigation of whether they could be a surgical candidate.
But it's not like brain surgery is a simple thing. Why wouldn't you just try to change the anti-epileptic drug regimen, or add on more medications like we would with a patient with refractory headaches? The answer is, more drugs doesn't mean more benefits in patients with epilepsy.
Trying a 3rd, a 4th, a 5th drug, the likelihood that those medications will make someone seizure-free is less than 5%.
Sure, these gains aren't inconsequential. I mean, we get less of a benefit in treating stroke patients with aspirin, but that still remains a standard of care. Think of the side effects of the AEDs, the toxicities of them. Think about how many seizures the patient is continuing to experience, how this is interfering with their quality of life, how it can be stigmatizing, and how it can keep people out of the workplace. More effective options are called for, and one that's tried and true happens to be surgery. But who's a good candidate? Experts agree, like Dr. Becker said, that patients must have drug-resistant epilepsy, meaning they've failed 2 or more anti-epileptic drugs at appropriate doses despite months of treatment. So there's your first criterion. The second criterion is simple. Does your patient have an identifiable seizure onset zone? Then there's the consent process, which is often a series of conversations with the neurologist, a neurosurgeon, and a neuropsychologist because it is a big deal. However, most neurologists don't even get to this point. There's too much fear, even among healthcare providers, about the risks of brain surgery, that there could be major cognitive, psychiatric, and psychosocial consequences of resecting such a large chunk of brain tissue. What if the patient comes out with a field cut and they can't drive anymore? What if they exit the surgery and their memory is completely wiped? Is surgery worth that risk? And yeah, it is brain surgery. The patient could die on the table. So it's not all that surprising that of 750,000 Americans who suffer from drug-resistant epilepsy, many who could be great surgical candidates, only 1,500 epilepsy surgeries are performed in the US every year. And both of the 2 major randomized controlled trials of surgery versus no surgery in refractory epilepsy were plagued by poor enrollment. The first study, that was published in 2001 by Wiebe and colleagues, included 40 patients in each arm of the trial. And the 2012 ERSIT trial didn't even recruit 40 patients. In spite of these limitations, the results of both trials and other observational studies have been strongly positive and favored surgery for these patients. And it's hard to know each and every one of the reasons for failed referrals because epilepsy surgery is such a patient-dependent process. Not everyone goes through the same procedure.
Epilepsy surgery techniques are very different. The most commonly known is for temporal lobe epilepsy.
This is Dr. Myriam Abdennadher, a former neurosurgeon and a current epilepsy fellow at the NIH who studies drug-resistant epilepsy.
And for an epilepsy surgery, the patient will be asleep under anesthesia, and an incision of the surgery area is done. So for temporal lobe, they follow an RC-form temporal incision followed by a craniotomy. If there is no lesion, oftentimes they do a resection of the temporal lobe that is already pre-studied and safe to resect for the patient's epilepsy. Several techniques are used and depends also on the surgeon's habits also. And some prefer selective amygdalo-apipocampectomy, and others would choose to do a total anterior temporal lobectomy.
The difference between selective amygdalo-hippocampectomy, or SAH, and anterior temporal lobectomy, or ATL, is important to make. There are as many opinions on the matter as there is uncertainty of the data, but I'll try to do it justice to summarize what we know. As a general rule, resecting more of the affected cortex or the suspected lesion is going to give you better seizure control. So when it's safe and risks are minimal, greater resection is optimal. However, there are a few instances when it may be more appropriate to resect a smaller area. Left-sided temporal lobe epilepsy, for example. The majority of patients have established their language system on the left side, so most surgeons will resect less from that left temporal lobe than from the right. It's also common to perform selective amygdalo-hippocampectomies in patients with mesial temporal sclerosis, since you know precisely where that lesion is, and it's worth trying to avoid permanently removing normal brain tissue.
Other surgeries can be addressed to more generalized epilepsy, like Lennox-Gastaut, and they consist of corpus callosotomy to disconnect the side of the seizures and minimize the risk of drop attacks, for example.
And if the patient and surgeon agree on a more conservative approach, for example, trying to preserve areas of eloquent brain by resecting a smaller area of tissue, you can always go back and cut more out if the patient's seizure burden remains substantial. Up to 10% of patients may undergo a second surgery, according to published case series. There's currently limited data on reoperation for failed epilepsy surgery, but a few small cohorts have reported some degree of success. However, some of these attempts are considered palliative. In one of the earliest retrospective cohorts of 27 patients who failed surgery and underwent a second resection, 20% of patients ultimately achieved seizure freedom. According to the investigators, the most common causes of treatment failure were dual pathology, meaning more than one source of the epilepsy, recurrence of tumor, limited resection to preserve function, widespread developmental abnormalities, and electrographic sampling error. In contrast, successful outcomes resulted from removal of recurrent tumors, from completion of a functional hemispherectomy, or surgery after repeated invasive monitoring to correct for any sampling error. According to more recent data, no doubt given the improved techniques and utilization of advanced neuroimaging, the likelihood of seizure freedom after a second resection can be as high as 40 to 60%. But let's just get back to the first surgery, the indications, the risks, and how it's done. Here's Dr. Abdennadher again.
Like any surgery, there are risks of anesthesia and risks from surgery. The major risk is the risk of hemorrhage that we can see after resection. We also see some risk of ischemia in case of a major branch is injured during the surgery. Other immediate complications can be due to infection, but it is considered very rare.
And then, of course, there are unforeseeable complications. After all, it's brain surgery.
Long-term risks affect memory in resective surgeries, and also some, if an eloquent area is injured, they can have a deficit, a motor deficit, or a visual field defect from the resection itself. But usually all the pre-surgical workup is targeted to avoid these kind of complications.
Prognosis for these types of procedures has been extensively studied in cases of temporal lobe epilepsy. For the most part, this group of patients is a more homogeneous sample as compared to patients with focal cortical dysplasia or tuberous sclerosis-associated epilepsy. These other cases of so-called extratemporal epilepsy are rife with inconsistent data and unbalanced groups, and you can imagine that they're very hard to control for. What would you control for? Would you take a patient with complex partial seizures because of a frontal astrocytoma and a patient with simple partial seizures because of a subfalcian meningioma and randomize them to surgery or no surgery? Would you consider them a nicely matched pair? Probably not, right? Their seizure etiology, semiology, and burden are all going to be incredibly different, and the likelihood that one would achieve seizure freedom is going to be much different than the other. I'd put my money on a more favorable outcome for the patient with that subfalcian meningioma and simple partial seizures. But when considering that more homogeneous population of patients with temporal lobe epilepsy, we've got decent data on the likelihood of a good response to surgery, and who would not have a good response. According to several meta-analyses of patients who undergo ATL for presumed temporal lobe epilepsy, factors associated with a better chance of seizure freedom include the following: complete or extensive resection of the temporal lobe lesion, seizures without loss of consciousness, which would suggest that they're likely to be a primary generalized form of epilepsy, and prolonged febrile seizures. Conversely, factors associated with a poor response to surgery include non-lesional epilepsy, a normal brain MRI, preoperative generalized tonic-clonic seizures, and infantile spasms or tonic seizures. Age and sex seem to have no bearing on the likelihood of seizure freedom with surgery for temporal lobe epilepsy. Following ATL, the next most common form of brain surgery for localization-related epilepsy is frontal lobe surgery. According to a 2012 meta-analysis of nearly 1,200 patients with frontal lobe epilepsy, long-term seizure freedom was achieved in almost half of cases, 45%. Similar to what we saw in meta-analyses of temporal lobe epilepsy surgery, the predictors of a favorable surgical response included lesional epilepsy, an abnormal preoperative MRI, and total lesion resection within the affected frontal lobes. All these things considered, it's increasingly apparent that localization-related epilepsy in the setting of an obvious lesion, whether it's frontal or it's temporal, whether it's mesial temporal sclerosis or it's a cavernous angioma, these lesional epilepsy syndromes are more effectively treated with total surgical resection than with multiple AEDs. And with such strong data supporting surgery for drug-resistant epilepsy, what's keeping us from taking these patients to the operating room sooner? Should we be considering surgical resection in patients before we attempt to control their seizures with medications? Of course, there are going to be obvious indications for early and aggressive surgery before we wait to achieve seizure control with AEDs. Glioblastoma, for example. With that tumor, the best course of therapy is early and aggressive surgical resection. But I'm curious as to whether more benign intracranial lesions that present with seizures are better treated with early surgery. Probably not, and Dr. Becker agrees. Again, it's still a risk and benefit situation. The fact of the matter is, it's the 21st century. We have a lot of anticonvulsant drugs we can offer which are associated with very mild and very tolerable side effects, and brain surgery is still brain surgery. The history behind all these things that we've been doing in neurology is super fascinating to me, and some of the early research on ablation involved patients with psychiatric disease or with movement disorders, and even less than 100 years ago, surgeons would remove parts of the brain that was responsible for movement for patients who had dystonia or tremor, and not surprisingly, the patients would then lose the ability to move the affected limb after surgery. And that sounds crazy now.
Yeah.
Are we going to look back in 50 years and say RNS, VNS, stereotactic laser ablation, temporal lobe resection, are we going to say that those techniques were crazy?
I think so. There's probably in the next generation will think we did some crazy things here. It's not surprising. Some of them is major surgeries, like I think corpus callosotomy is a very dramatic surgery. Maybe in the future they will find this aberrant, or can anterior temporal lobectomy, which is the gold standard now. Maybe in 50 years they will be shocked to hear about it.
Mm-hmm. And we still resect entire hemispheres for Rasmussen's encephalitis, for example.
Yeah.
So whether you call it crude or crazy or innovative, surgical resection for localization-related epilepsy is effective. Moving forward, we need to establish efficacy for the surgical treatment of extratemporal lobe epilepsy in randomized clinical trials. Maybe we'll find that it won't be as effective, or maybe the risks will be much greater when compared to temporal lobe epilepsy surgery. Also, we need better and more consistent outcome measures for these trials. Some of the common metrics used in major clinical trials are clinical seizure freedom, and a reduction in the number of clinical seizures by 50% following the intervention. But people with epilepsy are notoriously bad at remembering when or if they've even had seizures. More precise monitoring and objective metrics should be utilized to confirm the benefit of surgical intervention. And lastly, there are obvious deficits in our rates of referral for epilepsy surgery. Spreading the word about the success of this type of procedure, both on seizure burden, quality of life, depression, and quantity of life, is critical in order to provide our patients with access to the best resources for their condition. So keep that in mind as well, and share this information with your friends and colleagues. Don't be scared, it's only brain surgery.
Yeah, by mistake they find out it works.
In the next 2 weeks, you'll be hearing more about the minimally invasive alternatives to brain surgery for drug-resistant epilepsy, because the fact of the matter is, as many as 20 to 40% of patients with refractory seizures will not have an epileptogenic focus in the temporal lobe that's going to be amenable to surgery. And many more patients won't be good surgical candidates for a variety of other reasons. These other options exist specifically to meet the needs of these patients, and they happen to be highly effective as well. So stay tuned for more. As always, Brainwaves is intended for medical education and entertainment purposes only. While it's hugely important to raise awareness for the surgical management of drug-resistant epilepsy, do not misconstrue this program for medical advice, and definitely don't use it to justify brain surgery. Talk to your doctor about each of your medical conditions. This week's episode was produced by me, Jim Siegler, music courtesy of Little Glass Men, Montplaisir, 3 Chain Links, and Squire Tuck. If you've got an idea for an upcoming show or want to give us some feedback, you can reach me at bweditorialboard@gmail.com. I'm Jim Siegler for Brainwaves, and talk to you again soon.